Good afternoon, everybody. It's Monday at 12:30 in our weekly Instagram chat. Dr. Michael Jacobs here. We're doing something a little different today and having this being a open forum, so to speak. And I very much appreciate those of you who sent in some questions ahead of time so I can get started by addressing those. And rather than having a specific topic today, I'll jump around, answer the questions that you guys have online or live, as well as what people have sent in to us ahead of time. So we'll try and address them all and go from there. And the first question is one that a lot of patients ask us by Angie, and the questions were multiple questions regarding COVID and present understanding of where we are now with our understanding of it and how this may affect people's treatments and so forth. So as everybody knows, Florida has become sort of a hotspot for COVID infections, with the number of people being tested and being found positive. There's no present stay-at-home order in Florida, although I think the best way to look at things is we need to have a be smart attitude. We have more COVID in Florida now than when everything was shut down in March, and the issue is that I think science has learned a lot in the past 3 or 4 months. Whether you're going through fertility treatment or not, you need to be careful and minimize the risk of getting COVID in general, and if you have COVID, to minimize the risk of spreading it to anybody else. So common sense stuff, any symptoms at all, stay home, get tested, and realize that anybody that you came in contact with, particularly in the 2 days prior to having symptoms, could also potentially be infectious. So wearing masks, staying safe distances from people, trying to avoid congregating in big areas, avoid parties, barbecues, even going out to restaurants, even though outside dining, I believe, is still available. It's probably not the best idea, particularly if you're trying to conceive. The questions is, are pregnant women at high risk? Nobody knows if pregnant women are more susceptible to COVID than non-pregnant women. The concern is that when you're pregnant, whether you're pregnant with COVID or any other respiratory illness, particularly later in pregnancy, when you've got a big abdomen and not as much expansion in the lungs as you might, and your weight's higher because you're carrying around a baby, becoming ill with any viral infection is probably not the best thing in the world. And COVID is just, from that standpoint, another viral infection. The more concerning things is the questions of, does COVID cross the placental barrier, or does the placental barrier actually protect the baby in this case? And the answer to that is not really known. COVID has only been around since, in this country since, March, basically, February, March, undetected probably prior to that for a month or two. And pregnancies take 9 months, and we don't have the answers as to people who were exposed to COVID early in pregnancy. Does it cause birth defects? Does it cause miscarriage? Does it cause fetal demise later in pregnancy? These are all very good questions that unfortunately we don't have good answers to at the present time. So what options do people have? If this is the time to get pregnant for you and your partner, then it's fine to get pregnant. There are no recommendations by any of the medical societies to tell people not to get pregnant. But I think people who are getting pregnant need to be a little smarter and a little safer than you might be if you're not trying to get pregnant. you need to follow all the guidelines, mask, social distancing, or else potentially you're putting yourself and your future child at more of a risk than might be there. The question of should you delay pregnancy and what to do in the interim, that's a more complicated question, and it brings up the options of using fertility preservation methods with either egg freezing or embryo freezing. And certainly for women who are older, whose ovaries aren't functioning as well because they have diminished ovarian reserve, consideration for this makes a lot of sense over doing nothing and just hiding out, staying low until this whole thing passes, because we don't know whether a vaccine will be coming down the road in 6 months or a year, and when it does come down the road, how much protection that's going to give people and for how long. So it's totally fine if patients are uncomfortable right now with things the way they are, but if you want to preserve fertility to kind of maximize your potential of getting pregnant down the road with the capabilities of your ovary at this point in time, now is the time to begin to think about it, and we can certainly treat you, create embryos, put them in the freezer. Once the embryos are frozen, they can stay in there for years and years and years. The longest an embryo has been frozen and then found to be successful, resulting in a baby, was 25 years. So obviously most patients aren't going to use their embryos 25 years from now. In that case, it was a donated embryo. But in practice, if you're uncomfortable being pregnant now, but taking advantage of your fertility now is important, then fertility preservation with embryo freezing is right up there, number one, at top of the list of things to do. Expectations as far as how COVID may affect our office and our ability to treat you at this point. We don't have any intentions of closing down in the short run. We've taken precautions to minimize patients being exposed in the office to COVID. With everybody wears masks. We have social distancing. We try and schedule people so that we're not overburdening our office. More importantly, we're using telemed as best we can for consultations, and that significantly decreases the number of people having to walk through our door every day. So we're doing everything we can to maximize everybody's safety. In patients who are doing IVF, we're also testing for COVID prior to starting injectable fertility drugs. And the main purpose of that is to ensure the safety for the patient as well as anesthesia in providing sedation for an egg retrieval. I don't anticipate a mandate to shut down medical services, even with the first shutdown as a physician's practice. Even though we're dealing with fertility, it's still considered an essential medical service, and as such, our rationale for shutting down then was in order to get proper protective equipment in place and to have patients have a better time to, all the science, basically understand better what the needs are and how to minimize the spread of this virus. So I'm not anticipating shutting down anytime in the near future. Obviously, if there's a state mandate shutting all medical services, that becomes a big issue. But even with the prior shutdown, fertility services was still considered an essential medical service. So we should be okay there, and would not expect any cycles to be shut. Okay, next question was how many IUI cycles can a patient have before moving to in vitro fertilization. Part of the answer to this depends on what the reason is that we're doing IUI in the first place. If we're doing IUI as a supplement to ovulation induction with Clomid or Femara to restore ovulation, then in that scenario, the IUI is really maximizing the sperm-egg interaction in the middle of the cycle by getting the sperm there at the right time. But the main treatment that we're doing is the fertility drugs to restore ovulation. And in patients who don't ovulate, before moving to IVF, you would want to have at least 6 cycles of ovulation, minimum of 4, maximum of 6, let's say, before you consider moving to IVF. If we're doing IUI in concert with an oral fertility drug like Clomid or Femara, then we recommend up to 3 cycles before sitting down with your physician, discussing should we stick with this treatment or should we move on. Statistically, if you haven't gotten pregnant after 3 cycles of insemination, particularly if it includes the use of an ovulatory drug to help time them, then that's time to think about, okay, we need to move on to in vitro fertilization. With IVF, the pregnancy rate for unexplained infertility is going to be about eight times higher than what it is with just use of Clomid and insemination. And with male factor infertility, the pregnancy rate can be 10 times higher or more with IVF. So you don't want to waste a lot of time and money doing things that have very low chances of working. And again, every individual patient has its own story, and you still need to review those questions with myself or my partners, Dr. Ackman and Dr. Chung, who'll be happy to address what it means for you individually. But in general, the answer is 3 cycles, and then need to consider more if we're treating just ovulation, then up to 6. Following question was, what are my chances of producing good quality eggs with an AMH level of 0.7? I'm just going to scroll to get some more people's questions here. With AMH level, just to remind everybody, stands for anti-Müllerian hormone, and AMH level is a way of checking for ovarian reserve. And ovarian reserve refers to the oomph of the ovary, as I call it, but basically the sensitivity of the ovary to respond to fertility drugs and produce eggs. And what all of us have been trying to do for many years is to try and have a better understanding of how can we counsel patients based on the least amount of invasive data and studies to be able to give them a sense of, are they going to be easier to get pregnant, harder to get pregnant, is their overreacting age appropriate? So to check ovarian reserve, you do a few things. The first thing we do is ask you how old you are, and patients who are older have more difficulty getting pregnant because the ovarian reserve is much less. The biologic markers of ovarian reserve are AMH level. The normal value is usually in the 1.5 to 2 range. Lower values imply that the ovary is going to be less sensitive to stimulation and act more like an older ovary. So if you have a 0.7 AMH level when you're 44 years old, that's probably not that bad because you're 44 years old. But if you're 35 and have an AMH level of 0.7, that suggests that the ovary is not going to respond as well to fertility drugs. Now, there's a large range of AMH levels at any age, and so although that's very helpful, it's not the only marker. FSH and estrogen on the 3rd day of the cycle is a helpful marker as well, and antral follicle count on the 2nd or 3rd day, as measured by ultrasound, is also a good marker of ovarian reserve and how it may respond. So, if an AMH level is 0.7, what that tells us is that we need to use a higher dose of fertility drugs to try and compensate for the fact that the ovary is going to be more resistant. And depending on the patient's age and the number of antral follicles and the sensitivity of the ovary, sometimes we're able to overcome that a little bit, and sometimes it's just the flag. It's not the cause of the problem. It's the marker that tells us there is an issue, and it's just harder to produce eggs, but certainly an AMH of 0.7 is a lot better than AMH of 0.1. So, it just tells us where we are. It means the ovary is going to act more like an ovary that's 40 years old rather than an ovary that's 30 years old. And it tells us how best to treat people as far as the dosage. And it also tells us that you probably should be a little more fastidious and a little more direct in going to treatments that are going to be more helpful in getting you pregnant. Doing inseminations alone, if you have a low AMH level, doing inseminations with clomiphene, occasionally we may get success rate, but the best approach to maximize the fertility at this point in time, when we know the reserve is already compromised, is to just do IVF as a direct treatment, basically. Next question was, I was told Lupron can cause immune flare. Can medicated FET be done without Lupron, just estrogen and progesterone, a natural cycle, a low stim? So the basic question here is, what are the different ways you can transfer embryos back into patients? The most common protocol that we use in our practice for embryo transfer is it's called a programmed frozen embryo transfer cycle. And that's done by most commonly putting a patient on Lupron to shut off the natural cycle about a week before a period comes down, whether it's with or without a birth control pill. And then once the ovaries are turned off, we can stimulate the uterus to formulate an ideal cycle. So uterus thinks you're 19 years old and having a perfect ovulation by supplementing with estrogen and progesterone. And that allows the endometrium to build up, and in the second half of the cycle, the progesterone allows us to time when to put the embryo back in. Now, Lupron itself, most patients don't have any problems with it. I'm not aware of it specifically causing an immune flare, but if you're under treatment for some organic disease and your rheumatologist feels that this is a problem for you, then we can obviously avoid using the medication. You can prevent ovulation from occurring and using a hormone replacement cycle by using a medication like Lupron, but using an antagonist, a GnRH antagonist instead of an agonist. Translated into English, instead of using Lupron, you can use ganirelix or cetrotide. That's the same medication that was used during the stimulation process to prevent ovulation. And we can use hormone replacement without any pre-treatment the cycle before and add the antagonist in to prevent ovulation, again with estrogen and progesterone supplementation, and time the transfer. So we do that when we need to speed things up and patients are in a hurry for whatever reason. We do that in some cases because we're just forced to for timing. And the third option is to use a natural cycle, which is our least favorite way of transferring it. For one thing, we don't know what day the transfer is going to potentially be, so it makes programming things and knowing that your schedule, our schedule, lab schedule all come together well is harder to drive. Second is that the big benefit from the patient and doctor standpoint, we're not a giant center. We don't have 10 docs. We have 3 docs in the center. And as much as you guys like your primary doc to do as much as possible rather than seeing our partners, we pretty much feel the same way. We prefer to see the patients that we constantly are seeing. We're happy to see my associates' patients and vice versa. But obviously the maximum doctor-patient relationship, the old-fashioned bedside manner part of medicine, is best when you have the most contact with the patients, and we can time things to make that happen almost always with a program cycle, and it's almost impossible to ensure that with a natural cycle. So program cycles are our preference. Low stim FETs, that's a real rare bird for us. It's really rare that you would need to stimulate somebody to get a lining to develop because you can achieve the same high dose estrogens with hormone replacement without the risk of complications of ovarian stimulation. So we don't use that approach except in real rare instances, and I'm talking about once every bunch of years. It's a real rare approach for us to take on that. So hope that answers most of those questions there. Next question, partner and I will be dealing with reciprocal IVF. That's terrific. There's a question of blood types. My blood type's O positive, my partner's O negative. Does the sperm donor's blood type matters? The reciprocal IVF, for those, particularly if you have a couple where both members of the couple are female, we're taking the eggs from partner A, fertilizing them, putting them into partner B uterus, and potentially doing a reverse down the road. It doesn't really matter what the RH type of the donor sperm is. Just like if you're any woman and you're married to a partner, or you're using donor sperm, whether your partner's male or a female, the concern is RH incompatibility, not from a getting pregnant standpoint, but from the concern that if the person carrying the baby is RH negative and you have an RH positive fetus, there's the potential of the host, the pregnant person, developing antibodies against the RH positive genetic locus. And it usually doesn't affect that initial pregnancy, but can affect a future pregnancy down the road. And that's what RH incompatibility is. Now, to prevent that, any RH negative woman who's pregnant, irrelevant of where the sperm came from, is usually treated during pregnancy at 28 weeks and then at delivery with RhoGAM. And RhoGAM is it's giving passive immunity to prevent your body from developing these antibodies that would affect a future pregnancy. So it doesn't matter. I mean, people don't go out looking for partners. I mean, they may ask, what kind of sports you like, or what kind of activities you like. Are you a nice person, or you're not a nice person? But choosing a partner because of their blood type doesn't happen naturally. It doesn't need to happen here either. If you want to eliminate the possibility of RH incompatibility, if the person carrying the pregnancy is RH negative, then pick an RH negative sperm. But again, if the egg is coming from somebody who's RH positive, then even if you have an RH negative sperm, you're going to have an RH positive embryo, and more than likely, and in that case, you still have the same potential incompatibility. So the best thing is, don't worry about what sperm you use, just have RhoGAM when you're pregnant, and that should take care of things. Next question I have is it's from Ivis, was how many eggs do you recommend for the implant? And for patients that don't have tubes, is the same amount of medication? So I think, and then there's a third, okay, and so let's clarify what the question really is here. First, we don't transfer eggs, we transfer embryos. So our goal is to get as many eggs as we can with IVF. So we stimulate the ovary with fertility drugs to try and produce as many eggs as we can, fertilize those eggs, and get embryos. The embryos that we transfer, we recommend transferring one embryo, particularly we want one embryo to go back, and that's the safest pregnancy. That's the best medical practice. That's how we get the best number of babies born. So we do our best transferring one embryo at a time. And the follow-up question was, if I don't have tubes, is it the same amount of medication? Whether tubes are present or not doesn't affect the dose of medication that we would like to use. What affects the dose of medication is our guesstimate of your ovarian reserve. And that's based on a combination of age, some biologic markers that we already spoke about, AMH, FSH, estrogen, antral follicle counts, and ovarian volume, and most importantly, past response to medications. If we know that, irrelevant of whatever the answers to the first questions are, that you've been put on a certain dose of medication and you had a certain response, we can use that to adjust how you're going to respond in the future. People usually respond in a similar, although not exact, duplicate mode if you do the same exact thing. So obviously we try and learn from past exposure to the medications and how to change them and modify them going forward. Whether the tubes are there or not doesn't play a role in the dose of medication. It does not play a role in how many embryos are put back in. Karen asked a question regarding last week regarding some medications that may be expiring and how much time do I have to use them, or should you use them at all? The correct answer to the question is that all medications have a defined expiration date by law, and usually it's about 2 years from manufacture. What that means is that the drug companies have done studies that suggest that over that 2-year period, the potency of the medications doesn't change, and it should act the way it's supposed to act and how it was originally brought to market to be used. There isn't anything magical that happens to medications after that period of time, but we don't know what the effect of it is, and from a practical side, we do not recommend using any medications that have expired. So if you use medications that are expired, you're using them at your own risk. If you have a good response, then fine. But if you don't have a good response, we don't know if it's because the medications are outdated or not. So we do not recommend using medications that have expired. Another question from last week's live event was, if you do not respond to oral medications or injectables on their own, does a combination of both work together? And there's a protocol that's referred to mini-stim in IVF, or in ovulation induction, and that's using either Clomid initially, and then at the end of the Clomid 5 days, you add injectable fertility drugs, which is the more traditional way of doing it. And then some people also use a mini-stim combination where they're using Clomid in addition to injectable fertility drugs. And the mini-stim approach has value in two different times. One, if we're trying to do insemination and get a couple more eggs to develop in a person who's sensitive to medications, you can often get them to ovulate, 3 eggs instead of 1 or 2 eggs. So it may improve the pregnancy outcome without having to go to a full injectable dose protocol. The second time we find it valuable, particularly in IVF, we do not find it valuable with the concept of trying to get less eggs in IVF. There's no value of less eggs in IVF. Overstimulating patients or aggressively stimulating patients does not give you less good quality eggs. And we know with IVF, the more eggs we have in total, the better our chances are going to be of having normal embryos, particularly in older patients, and the better our overall outcome is going to be from that batch of eggs that are selected. What's adversely affected with a high stimulation in IVF is the lining of the uterus, but as long as we're biopsying the embryos and putting them back frozen, then there's no adverse effect from being stimulated strongly and producing a whole lot of eggs. There's a subgroup of patients that are very resistant to high doses of medication and just don't respond by producing a lot of eggs. And in that case, if I've got you on a maximum dose of injectable fertility drugs and you only produce 2 or 3 eggs, I could probably accomplish the same thing using this mini-stim approach and at the same time save $5,000 of medication costs. So in that case, it becomes very advantageous financially and has no downside from a clinical side, and we'll end up with the same number of eggs and occasionally a couple or more. There are some people that will use Clomid with high doses of fertility drugs in patients who are very resistant, but usually, it may have a little bit of benefit, but it's not going to change things drastically in that circumstance. Some other live questions here. Does ERA, which stands for endometrial assay testing, have to be done a cycle prior to embryo transfer to be accurate or months in advance? Will the receptivity change? Most people have had ERA testing but not had them done multiple times. The initial studies that were done did take some patients who were abnormal, changed what they were doing and retested them and found them to be normal. But I'm not aware of any studies that did an ERA test, let's say in June, and then repeated it 9 or 10 months later to see if it would change at all. Theoretically, if the uterus hasn't changed, it shouldn't change, because the purpose of the ERA assay, it's looking at molecular markers of implantation based on a programmed embryo transfer cycle. So as long as you provide the same hormonal stimulation to the uterus should respond in the same manner, and then the ERA should not change. So I don't think there'd be any problem doing an ERA, within a year of putting embryos back in. And the question is whether you need an ERA test or whether it should be done. Our sense is the only time to consider it is with multiple failed embryo transfer cycles where we put back normal embryos. And again, it's somewhat controversial, so please check with your individual physician on that issue. I covered the COVID stuff, Angie, and we can address that again at a future time. Next question is, I have a partial septate uterus. Does that lower chances to conceive, and should I go with surgery even though it's partial? It depends what your past reproductive history is and whether it's a true septum or a what's called a bicornuate uterus. It's important to distinguish the difference of what the external contour of the uterus is. If the septum protrudes into the uterine cavity, more than 30% of the cavity, then we're concerned that that may be associated with an increased risk of second trimester miscarriage, an increased risk of infertility, an increased risk of malpresentation at delivery, meaning breech or transverse lies that would require cesarean delivery. So if you have a septated uterus and it's more than 30% of the depth of the cavity, because septums or partial septums that fall into this category can be easily treated endoscopically with good outcome, recommendation would be yes to consider repairing it. If it's a minimal septum, then I would be more reserved in treating those unless there was a previous history of both failed implantation or particularly recurrent miscarriage, again more second rather than first trimester. But a small septum, 20%, 25% of the cavity, you can be more conservative on. When a septum is over 30% of the cavity, then surgery becomes more, you should consider it. how a natural things such as seed cycling and pregnitude and fertility don't put much, that's all supplemental, nothing's been studied. Fertility tea just has, usually it's, what do you call it, from the bee jelly or something that goes into the tea that they make tea out of. None of these things have been proven at all. As long as the supplements you're using don't contain hormonal herbs in them at all, usually doesn't cause a downside, but there's not much scientific data to really support use of any of that. If a husband's sperm sample contains E. coli, can it be transmitted to the female? Any time there's the question is, where does the E. coli come from, and is it just contaminated from the ejaculation process, or is there inflammation in the semen itself? If we see a lot of inflammatory cells and things, we try and wash most of those out. If we know there's E. coli present, we would treat both members of the couple, preferably prior to insemination. So if we know there's an issue with the infection, we try and avoid that so that we avoid getting bacteria up into the female reproductive tract. E. coli in the tubal, up in the upper reproductive tract, yes, can cause infection. So if we know there's something there, we'll try and treat it. It doesn't mean it will cause infection, but obviously it's not a good idea to inseminate somebody if we know the sperm is contaminated. Mini IVF, I think I've alluded to a few minutes ago. You're not going to get better eggs out of it. The only advantage of mini IVF is saving money if at the end we're going to get the same 2 or 3 eggs. But if we can get more eggs with injection, that's the way to go with IVF. The more normal eggs we have, the better the chance of pregnancy. As a thank you for being successful at our center, you're very welcome. We're happy to do that. The last 2 questions here I'll address. One is epigenetics and egg donation, or epigenetics in general, as far as does the culture media that cultures the embryo or have any adverse effect on embryos themselves developing. And there's a lot of research being done on this. I'm not sure about it being specifically related to egg donation, but the key with picking an egg donor is picking a donor that meets the criteria for, 1, having good quality eggs, 2, having somewhat similar features and characteristics that appeal to you, and from our end, 3, that they're medically, psychologically fit to be an egg donor, and reliable in following through with what needs to happen to be an egg donor. And last question was, my partner has a 0 sperm count, which is unexplained. Can it be reversed? It depends what the cause of the low sperm count, of the 0 sperm count is. If you have azoospermia, meaning no sperm in the ejaculate, the question is whether the reason for that is obstructive or non-obstructive in nature. Obstructive azoospermia is something that you see, for instance, in a gentleman who had a vasectomy. There's nothing wrong with the testicles. Production of the sperm in the factory is working just fine, but somebody blew up the bridge on the interstate so you can't get across the river. And therefore the sperm's just not getting out. In that case, yeah, the vasectomy can be reversed, but the better approach nowadays is probably to consider aspirating sperm from the testicle or the proximal epididymis and using that in IVF rather than having surgery to put it back together. There are cases where it's not due to voluntary sterilization, but that the testicle itself just isn't producing any sperm, or there's an obstruction very, very early on. Obstructions in the microtubules of the testicle cannot be reversed, and so the answer is, unless it's a vasectomy, usually surgery doesn't work to reverse anything. If it's non-obstructive azoospermia, then surgery has no role whatsoever. And the question is there sperm in the testicle, but they're just not getting into the tubules, or is it that the factory is defunct and there's just no production? And that's very important to differentiate the two, because as long as there's sperm in the testicle, we can get you pregnant with using IVF and injection of testicular sperm. But if there's no sperm to be had in the testicle at all, then donor sperm becomes more necessary. There are a couple more questions, so I'll try and just go through these real quick. 35 with an AMH of 2.6 is terrific. Last question for patient with a very poor sperm parameters. What options in addition to ICSI can be used to pick the best sperm? With IVF, we use Zymot routinely in our practice. Pixie is these questions. These are just laboratory dishes that are meant to try and pick out a better sperm. We've tried Pixie in the past. We found that the best approach was to use the Zymot method, and it's just a mechanical separation device that the sperm swim through, and the ones that make it through the other end tend to have a better chance of fertilizing eggs. We get a higher percentage of sperm that are not as fragmented, and we get better outcome in our embryo transfers and embryo development of these patients. So we're constantly on the lookout for things that are going to improve our laboratory techniques. We think right now we're using what is state of the art. Our lab is real successful with IVF as well as IUI, and the key in getting you guys pregnant is really understanding what the cause of the infertility is, even if the answer to that question is it's unexplained or it's a little of this and a little of that. The real issue here is listening to the recommendations of what we're saying and the options that we are presenting. A lot of fertility treatment is, there aren't rights or wrongs. There are different ways of trying to get to the same goal. Some are more successful, some are more direct, some are less expensive, some are more expensive. But the goal of everything that we recommend is really to try and get you pregnant in a cost-effective manner, and most importantly, have you have a healthy, safe pregnancy and a healthy baby at the end of the day. So appreciate your time listening in. I hope we've addressed all the questions out there. I think this has worked out great. We very much appreciate you guys asking the questions and can specifically address the things that are on your mind. A lot of these apply to fertility patients in general, and I hope that's been helpful for you. If you have specific topics you'd like us to address, please email us and let us know, and we'll try and address them. And stay safe and have a great rest of the Monday. Bye-bye.